Hi, my name's Conor Delaney. I'd like to welcome you to another episode of MD Insight, and I'm excited to be here today with Dr. Kareem Abu-Elmagd. And Kareem runs our small bowel transplant and gut rehab program, and is obviously an international authority and maybe legend in the field.
Oh, thank you.
Kareem. But maybe you tell the audience a little bit about your team and some of the things that you're doing, because it's truly incredible.
Thank you very much, Connor. I think we're proud of your leadership for the last 5 years since joining us back to your home, Cleveland Clinic. And when I joined the Cleveland Clinic about 8 years ago and initiated the largest and busiest gut transplant and rehab center in the world. And that's because of your support and your leadership. And the mission of the program, or the actually center, is not just a program, is to advance the field of gut failure that was neglected for decades. And the reputation of the center speaks for the mission of the Cleveland Clinic, putting patient first, innovation in medical and surgical management, and training a new generation to carry the flag and the mission of the Cleveland Clinic for many years to come.
Yeah, I think that's the truth, and it's probably particularly critical in an area like yours because not many surgeons get to experience it. So unless somebody's lucky enough to work with someone like you, it becomes hard to learn those skills. So maybe talk a little bit about some of the kind of cases that the team sees, and some of the things that you get sent, because I know you get sent stuff from all around the country and the world, frankly. So what kind of things are they for the audience?
Well, this actually, I think, I feel that, if you're a believer, that God put me on the right track since I left Egypt in 1983. I lost my father when I was 6 years old, and I was born on one of the banks of the Nile in Egypt. And then I realized that I have the passion to help patients and not let any child lose his father or mother at a young age. Then I decided America is the best nation to give me the opportunity to advance the medical field. Came to Wayne State University in Michigan on a snowstorm day in February of 1983. Then I moved to Atlanta to work with Dean Warren, one of the best surgeons over the last century, and then continue my journey to work with Thomas Starzl, which was the first or another giant surgeon over the last century, and he did the first liver transplant in humans. And I moved to Pittsburgh at the time because I realized that management of portal hypertension, which was the specialty of late Dean Warren, was just a symptomatic treatment. Putting this in perspectives, that exactly what put me in a position to be interested in gut rehabilitation, of course, first transplantation. And that's why, with all 4 decades of experience, we were able, with the love we have to the patients and humanity, we were able to advance in the field of gut rehabilitation and make it a very special field for very complex patients that nobody can take care of them. And that's what brought me to the Cleveland Clinic with an excellent recipe, with an institution or enterprise with a great reputation, and the experience I gained over the last 4 decades in the different diseases of the gastrointestinal tract and the liver disease. I started with the liver transplantation. I was at the right time and right place with Dr. Starzl, and at the time in 1989, with his vision, he realized that I would be the one who can carry the mission to establish the small bowel transplantation, which was a forbidden organ at that time, and we developed the anti-rejection medication called tacrolimus or Prograf. And then after 2 decades of day and night experience with small bowel transplantation, make it a clinical reality, Then I realized that we need to complete the whole circle by initiating or developing the field of gut rehabilitation, so patient can have a personalized medicine. Those who need a transplant, we transplant them, and those who we can save their transplant, save them a transplant, save their own gut. That's what they tell all the patients. If I can save your gut, that will be the passion I have for you, because nothing better than our own organs.
Yeah, absolutely. And so you've got a huge STEP program now and gut lengthening program, and you're saving so many people from transplantation. But I think one of the amazing things is that, you know, when many people think of heart or lung or liver transplantation, it's a relatively standard operation. But when you talk about small bowel transplantation, there's probably no two that you've done. Well, maybe there's two that are the same, but it's, you know, sometimes stomach, sometimes pancreas, sometimes small intestine, sometimes colon. It's a very, sometimes multivisceral with liver. It's a really complicated decision to decide the right mix for the patient.
Absolutely, and I think you're absolutely right, Connor, that's why every day, like today, we go to the operating room. I didn't know what I'm going to do for the patient. I told the patient, I will do everything possible to fix you, but I didn't know what I'm going to do. So it was sometimes when I tell them that, they get a little bit surprised because they never hear this from anybody. But that's the truth, because we're dealing with a very complex patients. They have a lot of hostile abdomen that have 15, 20, 30 times abdominal operation before. And either because of the disease or because of the surgical mishap, patients need further management. And that's what we're dealing with. As a matter of fact, last year, we were able to establish a model that can predict for the patient and for the physicians, and hopefully this will be utilized by all centers across the globe to tell us what patients could benefit from transplant and what patient would benefit from gut rehabilitation. Of course, we definitely have to make efforts to train the new generation to do this type of complex surgery from the esophagus all the way down to the anal canal or the rear end of us. So most of the patients that referred to the Cleveland Clinic because of the reputation and because of the reputation of the institution and also reputation of the program and the leadership here, that they have either acute catastrophic event that nobody can handle them and they're very critical. They need a comprehensive multidisciplinary care, this is the unique feature of our center. And also they're chronically ill because of their gastrointestinal disease, or they have surgical complications or disease-related complications that make them disabled and unproductive for a long time, months and years in another hospital before they came to us, which is a burden on the healthcare across the country. And we always encourage the physician for early referral for this patient so they can go back on their feet, go back to the normal life, and enjoy their life and their gut, because nothing better than our own gut with a big meal in a Chinese restaurant.
There you go. There you go. Now, one of your other passions is around some of the other abdominal surgeries that people don't see very often, like malrotation. And you get sent, I know, a lot of complicated patients with malrotations that other people aren't sure how to handle. What are your thoughts about that moving forward, and how can we help, and how can we avail of your experience best?
Well, thank you, Dr. Delaney, for asking me this question. As a matter of fact, to just expand on the previous question, that there is many different types of intestinal transplantation. A patient who needs a transplant, usually sometimes they need the intestine alone. Sometimes they need the intestine and pancreas. Sometimes they need the liver, intestine, and pancreas when they are on liver failure. And if their stomach doesn't work, they need what we call multivisceral transplants, which is stomach, duodenum, pancreas, intestine, and liver, which is a very complex surgery that not too many centers across the country and internationally can do it. And because of the experience in developing this type of complex surgical techniques, that we learned how we can do anything in the abdomen. If you have any problem from the diaphragm down, sometimes I go above the diaphragm, and I teach my team to do that too, that we can fix it. There is nothing we cannot fix. Based on this experience, I realized that some patients or kids or adults who have what we call malrotation, which is congenital anomaly that the intestine does not rotate to 170 degrees for our anatomy to look like all of us, the intestine had the tendency to volvulize and to twist around the blood supply, and the kids and the adults sometimes lose the intestine. And early on in the 90s, I transplanted quite a few of them, that because the diagnosis is very difficult, and some of these patients, the physician and the surgeons did not make the diagnosis on time, and when they go to the operating room, the intestine was already dead. And then the only thing, either they live in intravenous nutrition, which has a lot of complications, or get it transplanted. Then I start thinking about how can we prevent this from happening. Historically, a Professor Ladd, or Dr. Ladd from Boston, created a procedure in 1936 called the Ladd procedure, but this Ladd procedure came short of curing the disease. Just trying to prevent this patient from having a bowel obstruction, not protect them from developing volvulus. That's why that initiated the hypothesis and the notion in my practice is, can I fix the intestine the way, complete the rotation that the child or the baby or all of us during development in utero did not have? And that's exactly what we did. We get a large number of patients. There is a society called Malrotation Society and website. Most of them are beautiful young women and young children. We were able to help them to protect them from losing their intestine and maintain their own gut rather than requiring a transplant. And some also of these patients develop dysmotility of the gut that we're able to fix and improve their quality of life.
Oh, well, thank you. I mean, it's truly incredible what you've done. You're a true surgical pioneer, Kareem, and what you've contributed to so many patients who couldn't have been looked after in other places is very special.
Oh, thank you.
Yeah.
Thank you.
Well,
thank you very much. One of the things that also Dr. Delaney, you, Connor, deserve a credit for your support since you joined us, and providing us with the human resources and financial resources to help the program continue growing in a multidisciplinary, complementary way. So when the patient comes to the center, everything from A to Z could be managed for these patients, because we treat the human being as a one unit, and whatever the patient needs, from heart to skeletal health, to nutrition, to infectious disease, etc., we all, one team, talk to each other and deliver the best care for the patient.
Yeah, no, it's been exciting to be able to do my little part, but in bringing people more together already, it was a phenomenal team. But the other side of it is the nutrition team. We have a fantastic medical nutrition team with TPN and dietitian, and a great collaborative effort. Thank you very much for the insight, a great discussion, and a pleasure to chat with you today, Kareem.
Oh, thank you, Connor. Thank you. Bye.